Good evening, and welcome to your favorite Tuesday night show here on blackdoctor.org. And this is House Call with Dr. Gigi. So I know you might be wondering right now, you might be saying, where is Dr. Gigi?
Where's
Well,
my girl?
here's, she really is a doctor, and sometimes doctors have emergencies. And so Dr. Gigi unfortunately had a patient that had a crisis, and while she loves coming here and talking about medical issues with you all and sharing her knowledge, a patient in crisis is always going to take priority, and so she is handling that. So send some prayers up to Dr. Gigi as she deals with her patient tonight. But we have Dr. K, aka Special K, with us this evening. So we're very excited to have her here, and we're going to be talking about lung cancer awareness. Before we get to that, we got a couple things I'd like for you to do. Number one, that is drop in the comment section where you're watching us from. We always like to know where you're watching us from all over the world. I have to say all over the world now because we're seeing people in South Africa and Ghana and the whole nine. So all over the world. Number two, if you know somebody that needs this information, please share it with them. Tag a friend, share it on your page, because this is an important information that needs to get out to everyone around the world. And number three, if you have a question, make sure you drop that in the comment section and ask the question, and we will get the question answered for you this evening. So I think I've said all the particulars that we need to get done tonight. Dr. K,
Hey,
how are you doing?
I'm all right.
Good to see you again. Welcome back.
See you too. Thank you. It was it's been a whirlwind. After October, we did an awesome breast cancer campaign, and I've been listening to you and Dr. Gigi give some great information about kidney disease, diabetes. I mean, the 3 sessions you all have been doing have been outstanding. Great information. And I know Dr. Gigi works hard coming to talk to everybody on Tuesday. And again, she is a practicing physician. That means that's boots on the ground, as we say. And she is working hard. And then for her to be able to give us great information week to week is just outstanding. So we wish her, she would say, a lot of luck tonight and blessings, not luck, but blessings with her patient as she continues to do what she's born to do, and that's to take care of us. So Dr. Gigi, we love you, and we'll try to hold down the fort. Okay.
We're definitely gonna try.
And so I talked with you and her to say, can I, please, let's make sure that we recognize, although this is National Diabetes Awareness Month, that we recognize lung cancer awareness as well. And that came from my experience with 3 friends this year who lost a parent to lung cancer. And I started digging into this conversation about lung cancer. And lo and behold, this month is also lung cancer. November is Lung Cancer Awareness Month. And it is the third leading cause of third cancer that dominates in the U.S. And it's also the highest cause of deaths of all the cancers that we have. So I think it merits a conversation this evening. So I thank you. And I invited my dear friend, Dr. Danielle Singleton, to join us because she is a hematologist, oncologist. I'm an anesthesiologist. And both of us will at some point, of course, connect when we're taking care of a patient. So I'd like to welcome Danielle Singleton. She is a Johns Hopkins graduate, undergrad. We don't need to go into the years, but she has enough years in medical school of medicine. She is also a Howard, a Bison, and the real HU graduate medical school. I couldn't get into Howard, just so you know how good she is. She took a residency at Howard, and her fellowship is at Howard. She has a lovely family. And so I asked her to join us tonight. So thank you, Danielle, for accepting my invitation, Dr. Singleton. And so I think we'll have a great conversation, Alice.
Absolutely. Thank you. All right, go ahead.
Well, no, I just want to say welcome to Dr. Danielle, Dr. Singleton. Thank you for coming on and really helping sharing some wonderful information for our audience.
Well, thank you.
So what I had to plan for us tonight, and I wanted to open the show with you as soon as you want to, but I want to, first of all, let's say that while this is Lung Cancer Awareness and Diabetes Awareness Month, these two, what you showed us over the last month with Dr. Gigi, is that it affects Black men. And we really need to think about how these diseases also affect the men in our community. Diabetic disease in terms of nephrologies and things like that, kidney disease, end-stage kidney disease, and lung cancer, they kill Black men at the highest rates. So it's worth a conversation. It's not, and I wanted to talk about in general, borrowing some numbers from the Black Men's Health Project, that 30% of Black men die more from heart disease, 60% will die from stroke, and 75% of Black men are less likely to carry health insurance, which is a big deal. And that this is also, tomorrow will be World AIDS Day. And so we want to also put in that we still have a high death rate from HIV and AIDS amongst our Black males. And then, of course, lung cancer, which is what we're here about, is the number one cause of Black men have the highest rate of death from lung cancer. And so I made a PSA, a public service announcement that coordinates with the CDC about lung cancer awareness in Black men. And so I hope that you'll enjoy it and like it, and then we can talk about it even more. Okay.
You and your best dude always hit the basketball court. You always play until exhausted, with your faces to the sky, your backs to the concrete, and your future to embrace. Your lives have a constant threat: the air you breathe. It puts you at risk of lung cancer. African Americans are disproportionately affected by lung cancer. Black men die from lung cancer more than any other race in the U.S. They are diagnosed at an earlier age due to early exposure to the leading cause of lung cancer: smoke. Let's clear the air for our little boys. Put the cigarettes down. Stop smoking. It's never too late.
Hey. So I hope that it got the message across. The PSA was targeted towards young Black boys who grow up experiencing secondhand smoke. And then, as we know, if you're a child of a smoker, and I was a child of a smoker, that you more than likely will pick up smoking. I was averse to it because I didn't like the smell of smoke. But we have to think about, as a young man it matures, and if he has started to smoke in his teenage years and then continues to smoke as an adult, that there's an accumulation of exposure, which increases their chances of lung cancer. I also, in creating the video, thought that, we need to think about our communities, and that all around us between secondhand smoke and then where communities of colors are located, that also increases our chances of lung cancer due to exposure from pollutants and smoke. So I think that, I don't know what your experiences were, but yes, my father was a smoker. The CDC launched a big campaign on their website targeting this conversation about Black men and encouraging them to stop smoking. In terms of health disparity conversations and structural racism, there's a big conversation now about the fact that cigarettes were targeted in Black communities that contained methanol, which was highly addictive. Yep. I think I remember the target on my father's pack of cigarettes. I can't remember which ones he had, but I do know that it had methanol in it. I remember that word around his cigarette packs. And if you were, growing up in a house full of men who smoked, I mean, you have to think about even my exposure now over the years. But there is a big understanding that through the Black cinema movies that were being produced, they were actually encouraging us to smoke. And now you have 60, 70-year-old men, you wonder, is there a connection from that type of promotion and marketing of cigarettes in our communities that they have a higher rate of lung cancer today? So that's just, there's just so many different conversations about how Black men end up with the highest rate of lung cancer and then also die from lung cancer the most.
That's true. I was actually going to say, Dr. K, that I too am a child of a smoker. My dad smoked from ever since I could remember.
Uh-huh.
But also with that, the advertisement,
Mm-hmm.
Black men of a certain age now, back then, a lot of them may have been involved in the Vietnam War, right?
Mhm.
Or they may have been in the military.
Mm-hmm.
And we know that in the military, smoking, at least back then, I don't know how it is now, but at least back then, everybody smoked. You got a
Mm-hmm.
cigarette, you share your
Mm-hmm.
cigarettes with everybody else. And that's actually where my dad picked up his smoking habit. Was
Mm-hmm.
when he went straight from high school into the military, into the Navy,
Mm-hmm.
and stayed in the Navy for 23 years. But he smoked like a chimney,
Mm-hmm.
and he smoked Marlboro. I
Marlboro.
remember the
Yeah.
Marlboro man,
Right.
right? So I remember that's what he smoked. But everything you said is so true.
Mm-hmm.
Yeah, y'all are touching on some big issues. One, hey, so I guess we're 3 for 3 in terms of being children of smokers. My father was a heavy smoker for a number of years. We talked about it before the show. There was always
Mm-hmm.
that haze in the living room with my dad, and or in the car when we're on road trips, and just he smoked Benson and Hedges. But the thing about it was, I believe recently, Cool. I
Mm-hmm.
think they said they're going to discontinue those cigarettes or something because of the menthol, how they were specifically targeted
Mm-hmm.
towards minority communities, especially even spelling it. It was called Cool, right?
Yeah.
And it was
Yeah.
spelled with an A, and everybody smoked those menthol cigarettes, and so and they were at Joe Cool,
Mm-hmm.
Joe the Camel. So
Mm-hmm.
there was really a push, and now you're
Mm-hmm.
talking about military. My father went to Vietnam
Mm-hmm.
in World War II, and I believe they were still continuing this practice in Vietnam. Y'all correct me if I'm wrong. Is they were giving cigarettes
Mm-hmm.
to soldiers. That was
Mm-hmm.
part of what you got in your package. You got your socks,
Mm-hmm.
and you got a carton of cigarettes
Mm-hmm.
because they knew, the cigarette companies knew, hey, if I create these smokers in these 18, 19, 20, 20 years, I'm going to have 40 years of profits.
That's right.
And that's during the time. Remember, during those times, that's when they were suppressing the information about how addictive it was and how damaging it was, right? So
Mm-hmm.
you have all this, they're suppressing the ill effects on the body. They're
Mm-hmm.
giving it to young men to get them addicted, and then
That's
they're
right.
targeting minority communities with
Right.
these ads and with these menthol cigarettes. And so it's diabolical on multi levels on how we got to this point. And now, seeing the results of that, and that's a high rate of lung cancer, high rate of lung cancer death among Black men.
Very true.
Nicotine addiction. Excuse me.
Mhm.
Nicotine addiction is very powerful.
Mm-hmm.
It is. That's
Takes
all right.
take somebody over. Somebody take over.
Go ahead and take a drink of water, Dr. K.
Dr. Danielle, help our audience understand what are some early signs if they feel like they might have some early warning signs of some lung difficulties that could be cancerous. Because I know we've had pediatricians on talk about asthma and childhood asthma. We talked about COPD. Are the symptoms different when it comes to lung cancer? Are they similar? How can somebody know if there's something wrong with their lungs?
So that's a very good question. The difficulty with lung cancer is that it can present in a number of different ways. So we started off talking about smoking, cigarette smoking. So if you are a cigarette smoker, which I hope you're not, but we know that a lot of people are addicted. So if you are a smoker, there was a large randomized controlled trial that was done probably now about 10 years ago that showed cancer screening, specifically lung cancer screening, showed that low dose CT scans or CAT scans found earlier stage lung cancers. And I'll get into the staging in a little bit, but earlier stage lung cancers then did chest x-rays. And we know with all cancers, the earlier you find the cancer, the better your chances are of beating that cancer, right? So this study showed that low dose CT scans for patients who had been smoking at least 20 years, if they were between the ages, now in the study, they were specific ages, rather weird, like 54 to 74 or somewhere around there. But now they've actually just kind of broadened it to ages 50 to 80. You should have a low dose CT scan yearly if you've smoked for about 20 years. And if your life expectancy is about 10 years. So one way to try and diagnose it early is to have those low dose CT scans. Now, if you're not a smoker, some symptoms that you may present with can include a cough, which can be rather vague, right? Many things can cause a cough. Things like a cold, the flu, et cetera, can cause a cough. Sometimes if you have reflux or acid reflux, that can actually cause a cough as well. If you take certain blood pressure medications like lisinopril, that can actually cause a cough as well. So a lot of times what we find with patients who present with lung cancer is that they may have a non-productive cough, meaning a dry cough, meaning that you're not bringing up a whole lot of phlegm. Not to say that if you do bring up phlegm that it can't be cancer, but a lot of times we may see patients that don't bring up anything, but they have this persistent cough that you just can't get rid of. That's the most common symptom that we may find. Other symptoms are symptoms that you would see in COPD or asthma, such as breathlessness or becoming really short of breath very easily. May get to the point where you become short of breath with very minimal physical activity. Now, if you're having other symptoms like bone pain, that's just kind of came out of nowhere, that can be kind of vague, but that would mean, or that could point towards a type of a cancer that may have metastasized or spread from its original location, like from the lung to bone, for example. Now, I don't want to jump to a whole lot and say, if you have bone pain, you have cancer. That's not what I'm saying. I'm just saying that some things that you may, or a patient may experience if they have lung cancer or lung cancer that may have spread from its original location.
So it sounds like, and I've heard this before, so correct me if I'm wrong. I'm the layman on this panel, but so we have to really kind of look at risky behaviors more so than symptom in terms of physical symptoms, right? So if you are smoking, we've already talked about that, or if you're exposed to smoke. If you live in an area where there's a lot of pollution, and a lot of, they tend to put that red line around areas that are highly industrialized, that are closer to highways with a lot of car pollution. So those types of, you have a lot of pollution in your area, smoking, a family member, somebody in the house smokes, if you're exposed to smoking, carcinogens. I learned this recently, that if you're, that the burnt ends on the, we like to eat our barbecue, that crispy burnt part that some people like to eat, that's a carcinogen that could be cancer causing. So you should be burning your barbecue. Still grill, just don't burn it and ingest those things. So those type of things are risky behaviors, are more at-risk behaviors that you should be reporting to your physician that say, hey, I am a smoker. I'm around all of these. I ingest a lot of smoke. Even if you work at if you work at a barbecue place and you're inhaling a lot of smoke, that could be something. So I think you have to pair it with risky behaviors more so than looking for physical signs. Does that sound about right, Dr. Danielle?
I would agree. That's actually very true, Ellis. Definitely, you want to avoid risky behaviors, as you mentioned, but then also you want to develop, if you haven't already, good behaviors or more healthy behaviors, right? So exercise, and I know you've heard this 5 million times. I myself,
keep saying it.
But it's true, right?
Keep saying it.
So exercise, a healthy diet, containing, if you do not eat meat, you still need that protein, healthy fats, how to limit the carbohydrates, vegetables, of course, and fruits. But you have to move, whether that exercise is walking every day. If it's more rigorous, that's great, but you've got to get your body to move and to try and stay as healthy as possible. there have been studies that have found that the more the more sedentary a patient is or a person is, the more likely they're going to develop some type of a cancer. It may not necessarily be lung cancer, but it could be another type of a lung cancer. So we know that exercise, a healthy diet, and just healthy living altogether reduces your risk of these cancers.
It's always a formula. There's a good question in the comment section. I'm going to put it on screen, but they're basically.
I'm going to piggyback on something that she also said, and both of you all said, now that I've cleared my cough. So, you have the allergic cough, and then you have the, and that's what, and first of all, we'll just go back to the idea of a cough, which Dr. Singleton pointed out. We all cough, during COVID. I mean, if you were to walk into the grocery store, people start to freak out because you have a cough. The cough now is something, like you said, that we're paying attention to, like, oh my God, their cough. Is it a wet cough? Is it a dry cough? I mean, these are the things that would tell us about illnesses. I mean, I grew up in rural Georgia, so there was not an X-ray machine within 30 miles. Right. So your grandmother knew how you were doing based on that cough. I mean, and the thought that our grandparents also had tuberculosis. It was the cough. And so now that we have sophisticated means of diagnosing people, the first thing is the sound of the cough. And some of us who have children who cough, you say, wait a minute, what's that cough? It sounds wet. It sounds dry. Where's your inhaler? Did you cough before practice or after practice? So I think that, when we think about the cough, we have as physicians to create a differential already in our mind, even before we start to order tests, and also understanding that everybody can't run to a X-ray machine or a CAT scan when you get a cough. And sometimes what we see is that even when patients present to the emergency room, some patients, and this is where we get into the disparity issue, some patients get the chest X-ray. Right. Some patients get the CT scan. Some patients are told to go home and take cough syrup or go buy some cough medicine. Or we prescribe Tessalon pearls. And if your cough doesn't get better, come back in 3 weeks. So this is how different it is that a patient, in terms of care, that a patient can get treated and then their treatment delayed. And that cough that you presented with needed to be X-rayed, followed by a CT scan. And no one bothers to ask you, were you around childhood smoke? Does anybody in your house smoke? Where do you live? Do you live in Beaumont, Texas, next to plants? Do you live near Baton Rouge, Louisiana, where the air pollutants are abundant? They may not even ask you that question.
Right.
We talk about years of smoking for one pack of cigarettes, and then you multiply that by your years of smoking. So someone says, I smoke a pack a day. That's 5 days out, 7 days times 10. That's 70 pack years of smoking. That translates into how much of your risk goes up based on those pack years. And so people say, well, I only smoke a half a pack. Then again, you multiply that by the number of days in the week times the years. So imagine if you started smoking at 10. And some rural states and even upstate, yes, people do smoke that early, maybe 3, maybe 2. So you develop a cough and you don't think that it's anything, but you haven't been evaluated for all of your risk factors that put you at risk for lung cancer.
Right.
So just wanted to, bring that forth. And there was something else that you said, Dr. Singleton. We're screening people for lung cancer now based on their risk factors. Is that true? I think that's something new, right?
That is true. It's relatively new. So the study that demonstrates the efficacy of doing CT scans versus chest X-rays was published probably about close to 10 years ago. However, we all know that some things are kind of slow to come to practice, right?
Right.
Prior to that, chest X-rays were
the mainstay.
Exactly. That was the mainstay. That was what was supposed to happen. Not to say that that's what did happen, but that would be all up to your primary care physician. Now, if your primary care physician isn't aware that you have this cough or, that you're smoking. And again, it does start with the patient. So if you don't let your doctor know, the doctor isn't going to know to do X, Y, and Z. So, yes, so the chest X-ray has been it was the mainstay prior to this study. It was the non-small cell lung cancer screening trial. It was multi-center, multi-countries, had over 53,000 patients involved in the study. But what it showed is that these low-dose CT scans done yearly in patients who have a high risk of developing lung cancer, they showed earlier stage, meaning smaller tumors of lung cancer than did chest X-rays. The CT scans, as you know, they're able to show a lot more detail than a chest X-ray can show. And so on the chest X-ray, if you have a really large tumor, you'd most likely be able to see that. However, if that tumor is really small, like 1 centimeter or half an inch, you may not be able to see that on a chest X-ray. So the CT scan, it allows the doctor to see a lot smaller of a tumor, smaller size of a tumor, and therefore most likely an earlier stage. And we can go ahead.
So I just want to, not to cut you off. So I just want to make sure we emphasize the point that you said earlier, that this is not an automatic that you get this screening. You must tell your physician that you have risk factors for lung cancer, meaning you've been exposed to smoke, or that you've had, some questionable cough, or that you yourself quit smoking at some point. And
right.
They may go ahead and order that. But you also said that some physicians may not be aware that this is it a covered cost for healthcare screening?
Very good question. So I actually just looked this up because Medicare does cover the low-dose CT scan if your doctor documents the fact that you have these risk factors.
Yes.
We mentioned, right? The smoking history. If you smoked and you quit, Dr. K touched on this. If you quit, but it was less than 15 years ago, you still are considered high risk. Or if you have secondhand cigarette smoke exposure within the last 15 years, you do fit into that high risk category. So I do know that Medicare will cover the low-dose CT scans yearly. However, I don't know about private insurance, but most private insurances do tend to follow Medicare. But that would definitely be something that I would check.
So Ellis, when you talked about Blue Cross Blue Shield, you could ask them, how committed are you to eliminating health disparities, and are you covering this 100%? Because when we think about Medicaid in terms of what they'll cover, someone will say, well, I have Blue Cross Blue Shield, but they don't cover 100%. Let's say you're 45, and you don't have a reason. You're a working man, you kind of, you're just working and living your life and take care of your family. Should you ask your provider, and then your provider says, well, I can order it, but there's going to be a copay. Now you have to decide, is it worth the copay when you feel fine?
Right.
But like Dr. Singleton said, you could probably get a diagnosis of an earlier cancer.
The challenge with insurance always has been they are trying to save money while trying to make money simultaneously, right? And so the money that they save is by preventing you from having a severe illness. So that would suggest that they should cover that screening, because that screening is going to be much cheaper than your treatment for lung cancer. However, they want to make money too, so they're going to make it on the higher rate plans. And most of us are trying to save money because we're living check to check, and we don't buy those. We don't purchase those higher rate plans that has those screenings covered. And so we get caught in this catch-22. And so I would, so that I'm saying all that to say, check your plan, know what screenings are covered, what screenings are not. When it comes to Medicare, we are still in open enrollment. You have until December 7th. You have until 1 week from today to enroll in Medicare. So please, if you have not enrolled, if your grandma hadn't enrolled, your mom hasn't enrolled yet, please enroll them. Healthcare.gov. go enroll, and you have until the 15th
Mhm.
for the Affordable Care Act. So even if you're under the age of 65, that's the line of demarcation. There's some other stipulations, but under the age of 65 is
Mhm.
Affordable Care Act, aka Obamacare.
Mhm.
That's until the 15th. Medicare 65 and above
Mhm.
is December 7th. There might be some extensions because of COVID, but don't count on that. December 7th, December 15th, those are your dates. Please go get some
Mhm.
sort of coverage to get some care.
So that also thinking about what you were saying, Dr. Singleton, in terms of bringing all of this home, there is we do have a responsibility in terms of trying to take care of ourselves. One of them may be saying, I'm going to pay this premium. I mean, this copay to get this screening test done. I mean, there are preventive things that we need to go ahead and do. Again, if you can, you kind of need to see what the price is, and at some point, if you feel like you're a risk factor, only to get the test done. The other thing is making sure that you do take care of yourself, like you were saying, exercising. They're also exercising and also eating healthier, making better food choices. But we want to make sure that we acknowledge that every community doesn't have, these resources, and that this is part of the reason this show exists, is to make sure that we can get the information out so you can take and hopefully advocate for changes in your community. I think we talk about Ward 7 and 8?
Ward 7 and 8. Yep. In DC. Yep.
Yeah, one of them got a new grocery store
Mhm.
that's supposed to bring in healthier food options. And there's also a cardiovascular NIH intervention that I heard about, where they were trying to encourage exercising. Again, starting with church-based programs is always a good idea to talk about cancer prevention, and then what are the needs of the community. That's still a big public health strategy, is to go into churches and ask them what resources or how they can assist with mobilizing the community to understand the needs of, need of exercising and better food choices. And I think DC has put up with councilmen, different areas, however you do it, mayors, councilmen, city council, to talk about what are the needs of the community. So with smoke, some of this is due to environmental advocacy that needs to be done as well.
Absolutely.
So as we know, in the spirit of Dr. Gigi, one of her favorite things we talk about each time we do this program is social determinants of health. Right?
Yes.
So we talk about, and part of one of those social determinants is food deserts. And so you're going to hear that terminology happen, and it happens a lot in minority, low income, we'll even say all minority and low income communities that do not have access to high quality foods. So what happens is we get those ultra processed foods, and those are the ones that typically are more detrimental to our health. They are high in sugar, high in sodium, all of those things that are really detrimental to our health, which, as you can see, we have a disproportionate amount of Black people with diabetes, a disproportionate amount of Black people with hypertension. So all of those things. So how do we overcome that? So like now we're talking about solutions. What are the solutions for those social determinants that are already there in place? How do we overcome them? I think if there was a positive from the pandemic, it is everybody had to go home and had to figure out how to exercise at home. And so now there is this kind of big push for home exercise, and everybody doesn't have to buy a Peloton.
But you got your YouTube and you got your phone. But I will say, Ms. Ellis, that let me just tell you, the thing about those food deserts is they provide us with these corner markets, and these corner markets have what? They have lots of cigarette options.
Yes.
So not only are they not giving us good food options, they are also doing the counterpunch in terms of giving us lots of. Have you seen the cigarette selection behind some of these corner markets?
It's crazy.
Yes, it's crazy. So you almost wonder, when we talk about the social determinants of health or health disparity, which is also talking about structural racism, that this is a structural racist situation that communities are in. And where do you start? I mean, how do you get groceries in there like Whole Foods? Why is Whole Foods not in certain communities? What's the problem? Maybe we should have
the short answer is there's a higher margin of profit on a pack of cigarettes than there is on an ear of corn. And so if you run in a local bodega, you want to try to maximize your profits, and you know that people are addicted, and they're addicted to them.
They're addicted.
And so they're going to come in. You're not addicted to corn, but you're addicted to cigarettes. And so they know that cigarette smoker is going to come back and turn over and keep frequenting my store versus somebody that's eating healthy foods may or may not come in. And so it's about, is it bad? Yes. I mean, but we have to take responsibility for the decisions we put in our bodies. Yeah. So that's what we're having these programs. We're here to try to educate and advocate for people to say, okay, look, let's all make some better decisions. I've made some poor food choices in my lifetime. I can't complain it because I had a hot wing addiction. I had to get through it and work my way through. But I learned how many calories and how much trans fat are in those wings, and I was like, it's not worth it. My health not worth it.
Very true.
Very true. You said there was something in the chat room?
Yes. Oh, yes. Oh, so Dr. Singleton, this is a great question. And we've been talking about smoking, but this person said, how does vaping come into play as risky behavior for lung cancer?
Excellent question. So vaping has become, or it had become, very popular within the past few years. So we know for a fact that vaping can cause detrimental, or it can cause damage to the lung tissue itself. I think it's a little too early to say 100% that vaping leads to lung cancer. However, we know that it does cause, and a lot of times, irreversible damage to the lungs. So whether or not it causes cancer may not even be relevant, because if you lose your lung tissue, you cannot regenerate lung tissue. And you may end up on oxygen or having to be on the list for a lung transplant. So vaping, we found, is not any better than smoking. Sometimes it's worse than smoking, especially for the youth. For young people who start off straight out the bat with vaping, it's horrible. It does terrible damage to their lungs. Now, earlier on, we did find that for people who are having difficulty quitting smoking, they're smoking cigarettes and they're trying to quit, that vaping did assist them in the quitting smoking. However, that's for people who have been smoking cigarettes for years. They already have that underlying damage to the lungs. But vaping is not recommended, of course, by any healthcare professional, period.
Yeah, I think vaping, we always have these things where people chewing tobacco, and kids can be introduced to nicotine that way. When they're learning to play sports, particularly, I think our baseballers like to sometimes do tobacco pinches. I don't know what that's about. So I just see the picture. So these are things that we have to be aware of how the behavior becomes normalized. And once the behavior becomes normalized, it's easy to transition to smoking, and smoking in terms of leading to drinking and other behaviors that magnifies your chance of cancer, of lung cancer. And so as our young children, men and women progress, between the settings of just wanting to go out and hang out with friends, then then the bar scene, again, they're going through this haze of smoke, that they have to think about the fact that, later it's the accumulation. That's the thing about lung cancer. It's the accumulation. I can't say that I've seen a 20-year-old with lung cancer. I think our peak, epidemiologically speaking, our peak ages begin after 40. Is that correct, Dr. Singleton?
That's correct.
Okay.
The most common age is somewhere between 50 and 70.
So we're looking at an accumulation of the risk over time. And I think that's what sneaks up on people, that we have to decrease our risk. And that good thing is that you can. I mean, I remember when my father stopped smoking, coming home from college, and I was like, what's different here? And I was like, you're not smoking, and that was just like the best gift. And so now, as he's in his 70s, he's actually decreased his risk of getting lung cancer. It's not zero, but it's been over 15 years, it's been almost 30. So, that's what I say, it's never too late to stop smoking. And we need to keep encouraging our loved ones to please stop. I mean, I know you got some diehards. I have a family member. They're not going to stop smoking. They're just not going to do it.
Right.
But what we have to appreciate about lung cancer is that you can decrease the risk as you systematically eliminate the toxins around you, what you voluntarily put in your body, or what where you live. I mean, and some of those are just different social determinants. You can't change your zip code sometimes you can.
Right.
But bringing about awareness is key.
Exactly.
I think there's a mental health component to this, and so when we're talking about smoking and the cessation of smoking, we got to talk about how we got started smoking in the first place. And so I've seen a series of videos of people talking about the influence that person seemed cool, that they looked up to, that was driving a fancy car and he had the cigarette in the mouth, and so
or stress,
right? The stress related. Peer related. We talked about my son plays baseball, and some of the older kids on the older team, they dip, and that was, and then they share it with each other, and talked about, and we hear terms like peer pressure, but I don't think I've ever had a peer pressure mean to anything, and so we've got to change that terminology to peer influence, right? I had my first drink from a peer, and he didn't pressure me. He just said, "You drink, don't you?" And the answer was yes.
Yeah.
I didn't.
Or someone tells you, "Oh, I took a smoke because I was stressed out during exam period." I was like,
exactly. And so
cigarette.
And there's triggers, right? And so we have to recognize that even when we're trying to stop smoking, we have to recognize what our triggers are in our lives and eliminate and reduce those triggers so we don't fall back in those habits. That's how relapse happens, and how we go back into old behaviors. We get a trigger. So, I've heard cigarette smokers talk about they had to stop going into bars because they would drink and they would pair smoking with the drinking. And so there's a trigger. And so we have to recognize that there is a connection, not only just a physical dependence, but there's a mental and habitual dependence that comes with the smoking behaviors that we also have to deal with, not just the physical part.
You said something very important in terms of the mental aspect. One thing is I had an aunt and uncle married forever. And my aunt said, your uncle put down his pack of cigarettes and never picked them back up. Me, I'm having a hard time stop. So you never know if you have what we're talking about is an addictive gene in your own triggering. And then if you're able to stop smoking. So some of these, vices or bad habits, you may not know how. We talk about that even with opioids. Some people can stop cold turkey and some people progress. You just don't know what genetic codes you have. So it's best, not to do it. And then using, smoking and as a coping mechanism. When I've seen men in the primary care setting or working, it's like, I just need my smoke. I mean, I work hard, I'm doing this, it calms me down. And, can you imagine? I mean, my uncle works for like Georgia Power, telling him, go do a yoga class. He was like, huh? What are you talking about? No, he doesn't smoke. But when we say these things too, you have to meet the community where they are. Instead of saying yoga, I'll say, okay, well, I tell you what, go for a nice walk in the evening. What is it that relaxes you? So you have to meet community people where they are so that you don't give them unrealistic things to do. I mean, I've heard that, through, why don't they just, join the Y and do. Well, it's not what's happening. It's not what's happening. I'm not going there. So, once you decide, well, what is it that you will participate in? One study for Minority Men's Health said that Black men will typically participate in an exercise program if it is around a community setting or a social setting, like basketball. That's because it allows for them to, push, pull, kind of get out some aggression, that also show some love. And then, kind of before you know it, they're talking and they're laughing and they're engaging, and then boom. That's why that works better for saying, exercise, and as opposed to, go for a 3-mile run or walk. not happening. I mean, some brothers gonna do it, but what they found study wise, if you can create a group, which is why they have a Black Men Run group out of Baltimore. Saw them going off to Chicago. That was very empowering. They did it as a group. They encourage each other as a group. So those they also said that that Black men who are booed up or have a loved one, they kind of thought that actually was not an exercise enhancing, because they took on the role of provider, that you want to do things like go to dinner, that you want to do things like, work harder so you can buy that nice thing for your partner, so they said men who were engaged in relationships, happily engaged, would oftentimes not exercise more because they want to do things for their part. They took on the role of provider. So then you get into this conversation about their gender role and expectations, and expectations that you not come in here, drop your clothes, and then go back out to play basketball or to the gym. So I don't know if if you do that, Dean, but if you come home, you say, I'm going to the gym.
We try to go together.
Oh,
So
good.
That's good.
we try to do a boot camp on Saturday mornings, and then we did break down and get the Peloton, and so we had different challenges. Oh, did you do the Migos class? Did you do this class, whatever? And so there's different challenges there, and so again, that could be cost prohibitive for a number of people, but I would say it was for me. The common denominator is challenge your partner. And if y'all do it together and make it a weight loss challenge, make it a fitness challenge, because weight loss can be
a fitness
lost in the numbers. Make it a fitness challenge. Hey, I walked a mile in this time. I'm going to try to beat my time. And you track your results over time, and you do it together, and you encourage each other. You become accountability partners as well as romantic partners. You become accountability partners in your exercise. And so there's ways to do it that can fit whatever level of income that you have. But please do it. Movement at any point, even if it's just standing up and sitting down, doing squats at your desk, some type of movement is getting your heart rate up. It's going to be healthy for you. So I encourage everybody to do it.
So Dr. Singleton, when you have a patient, when does the patient end up coming to see you? I mean, I know when they see me. I mean, we're talking the pathway for a cough, and I think that if we rewind the tape for our audience to understand that, so you're exercising, you're trying to do everything right, or maybe you're not exercising, but the point is you're going about your normal livelihood. You develop this cough. The primary care doctor or the ER sends you for your imaging, and your imaging comes back suspicious. When would you expect to see someone to the hematologist oncologist?
So it can be at two different time points, if you will. So the patients that I normally would see in the clinic have already been diagnosed. In other words, they've already seen their primary care doctor. They most likely have also seen either a surgeon or an interventional radiologist.
If they interacted with me.
That's right, exactly. They needed that anesthesia in order to have these biopsies. So they've actually already been biopsied and diagnosed. Now, patients that I would see in the hospital, in other words, patients been admitted for one reason or the other, shortness of breath, for example, and something was found on a scan, CT scan, MRI, whichever. Now, I may see them before they've actually been diagnosed. Now, a lot of times, most physicians will see something on a CT scan that they think is a tumor. They'll automatically go ahead and consult the oncologist, even though it hasn't been biopsied and actually diagnosed. So I may see patients at that point, at which time I actually consult the intervention radiologist or the pulmonologist, which is a lung doctor, or a surgeon. Most times it's going to be either the lung doctor, pulmonologist, or interventional radiologist, meaning this is a radiologist who does procedures. So depending on where that tumor is in the lung, if it's closer to the middle part of your body, most times the pulmonologist or the lung doctor is able to actually pass a scope going into the mouth, all the way down through the bronchus or the windpipe, and into the lung to take a piece of that tumor. In other words, a biopsy. If it's more in the periphery, meaning that it's farther out towards your sides, if you will, of the lung, in that case, we're going to need to have the interventional radiologist use a needle to go actually from the outside into the lung and take a piece of the tumor that way. So we cannot diagnose lung cancer without a biopsy.
Right.
I've seen it so many times where another type of physician sees something on the chest x-ray or the CT scan and says to the patient, you have lung cancer.
No.
Hasn't been biopsied.
No.
It's terrible.
Yeah.
I mean, a lot of times it looks and smells like a lung cancer, but you cannot diagnose it without a biopsy, because I have seen a patient who had a very rare disorder, but it was not lung cancer. Sometimes it could be sarcoidosis. I think Dr. K and I talked about that before. Sarcoidosis can cause what looks to be tumors in the lung. It's not cancer. So usually, like I was saying, that's when I'm going to see the patient.
Now, do you come up with the chemotherapy plan? I mean, sometimes, what I've been involved in, so I'm involved with the initial diagnosis in terms of abnormal CAT scan. We need to go in and we need to do a bronchoscopy. So I'm in the pulmonology suite. So I really enjoy working in the pulmonology suite. And we go down and we take the biopsies, and my job is to render the person asleep so that we can get that done and get a tissue diagnosis. And then, so you take that tissue and take it to the path, and, and then we see what we have. So we have two types of lung cancers that we want to diagnose. And I'll let you, as the oncologist, tell us what types we have.
Okay, thanks. So there's, like you said, two general types. There's small cell, and then there's non-small cell. Now, small cell is a type of lung cancer all to itself. It tends to be more aggressive. And because of its nature, it's usually staged as either limited stage or extensive stage, because it tends to spread quickly, unfortunately. Now, with non-small cell lung cancer, that's more of an umbrella type of a diagnosis, because there's different types of non-small cell lung cancer. The most common types are either adenocarcinoma or squamous cell carcinoma. There's some less common ones like large cell or neuroendocrine, but the most common that you'll see, or that we see, is either adenocarcinoma or squamous cell carcinoma. That's right. And depending on the type, like we just mentioned, as well as the stage of the lung cancer, is how we develop the treatment plan. So as we were saying earlier, if we can catch it earlier in its stage, whether it's small cell or non-small cell, the better. Because usually what we'll do is offer surgery. In other words, if we can just take out that small tumor and it hasn't spread anywhere else, including the lymph nodes that we have in our chest, that is the most ideal situation, right? Because then that's surgery, right? And exactly. Higher chance of the cancer not coming back, higher chance of what we would say is a cure. We unfortunately don't see that often. Hopefully we'll see it more often when patients are being sent for these low dose CT scans. Earlier. Exactly. Exactly.
So the numbers that I read was that about 20 to 40,000 people die from lung cancer a year. Is what I read on the current numbers for the CDC. They usually publish these numbers en masse, as accumulation over the years. So the latest numbers say about 20 to 40,000 people die from lung cancer. And then, like you say, you can go in and take out localized disease, but there's always the risk that it could come back. So we have surgery, and then you also have, do we use radiation and chemo as our modalities for cure as well?
We do. So depending, again, on the stage and the type of cancer, we do use chemotherapy as well as radiation. More often than not, we're going to be using both of them either together or sequentially. So for a small cell lung cancer, for example, the more aggressive type, we're using chemotherapy along with radiation at the same time. Some of the chemotherapy agents that we use actually sensitize the tumor to the radiation. In other words, it helps the radiation to work. Exactly. Yeah. And same thing for some of the stages of the non-small cell lung cancer as well. But we actually have immunotherapy now, which has come into the market probably about 6 years ago.
Mm-hmm.
First one being Opdivo.
Mm-hmm.
We don't see too many Opdivo commercials anymore, but it's still around, still works. Because now we have several more, like Keytruda,
Yeah.
Tecentriq, right? Yep. All of those are immunotherapies, which actually uses your immune system to fight the cancer cells. And since they work differently from traditional chemotherapy, have a totally different side effect profile.
Do more women get small cell carcinoma in the lungs? We're seeing a gender difference in that one, if I remember.
Not necessarily small cell by itself, but actually lung cancer in general actually causes death more in women, unfortunately. And I did see someone mentioned in the chat before that they knew someone or had a loved one who had lung cancer and never smoked a day in their life.
That's right.
We've been talking about advocating for ourselves and doing the best that you can to prevent it. Sometimes it does occur and we don't know why. Right? We don't have all of the answers. Go ahead.
But the risk factors, of course, not just smoke, and I think that's what people understand. There's environmental.
Right.
It is.
They said there's also a check now at homes that have to be checked for radon exposure.
Right.
I don't know about older homes and older communities. Do they have to have this regulation in terms of any home now has to have the levels of radon documented? We also have to take into account genetics. So that if someone does not have a history of smoke, they check all these negatives, that it might be within their family a history where someone had breast cancer, somebody had brain cancer, and you are the person who has lung cancer. So that's why I think with Dr. Gigi, when she talked about the importance of talking to your family to hear, who had cancers, and then you may understand that there was a cancer gene throughout the family that no one really talked about. You just knew that someone passed. But definitely, if you have a family, this holiday is a time, we're talking about COVID, but it's also a time to really kind of ask for a family history profile. So, while we have these questions about how did we get lung cancer when there's nobody that smoked, there are still accumulated risks out there that we can't eliminate 100%.
I want to, as we're here, if you're watching House Call with Dr. Gigi, if you don't see Dr. Gigi, just please know, if you're just joining us, that she had a patient in crisis, and which is why she's not here. We also had a lung cancer patient that was scheduled to join us, but again, he is in treatment and he had to be admitted into the hospital. So we're going to send prayers up for both.
Thank you, Dr.
People that were not here with us this evening. There was something that when you were talking, Dr. Singleton, about the process of treatment. And I want to emphasize from a layperson standpoint is every time, whether it's the intervention radiologist or the pulmonologist or the oncologist, you have to go back. Okay. And so you have to follow up. And you might have one of those doctors that just throw something out there. Oh, it's a cough. Go get some cough medicine. Come back in 3 weeks. Well, if you don't go back, guess what? That small cell lung cancer, as Dr. Singleton says, is very rapidly growing. It's very aggressive. You gave it 3 more weeks to grow or longer because you didn't go back. And so it's incumbent upon us as the patients to do our follow-up. When the doctor's says you need to do this, go see this person, go see them. And I know, yes, is it inconvenient? Yes. Do you want somebody else poking and prodding and asking you all about your history? No, you don't want any of that. But I tell you what you don't want is lung cancer. And so please follow up and please do whatever your doctor is suggesting that you do, please do that to make sure that you're 100% healthy.
And even like we're saying with cancers, I think what we're finding out with cancer in general is it is a process. It's a process from we think you have something. Same thing we saw with breast cancer. Now we're seeing with lung. I'm thinking of something. I'm feeling something. I don't feel like something is right. Lung cancer is one of those diseases that can also present very atypical. You may before you know it, you really didn't have the cough, or maybe you just developed the cough, but then found out it spread everywhere. But the point is that it's a multi-step process to get a definitive diagnosis. It is overwhelming for patients. That's another thing that we have to admit to as a medical community. We don't make it easy for patients to come in and get answers quickly. That is frustrating. It's very frustrating too for communities that don't have easy access to health communities, whether you're located, particularly in the DMV, we call them medical deserts, where you're so far from a tertiary care center, center that can, has all these specialties in one space. How far are you from Hopkins? How far are you from GW? How far are you from Howard? It can be a lot, and it's challenging. And during COVID, we have to realize too, I mean, transportation and moving about hasn't been easy, even because you have a mask on today. So, but we want to acknowledge that, yeah, the medical community is complex. When you get something as simple as a cough, then understanding if you got sent home, do I go back? Then should I be given an X-ray or a CT scan? And then from there, if I'm told to follow up with a pulmonologist, and then from there, do I have to go see an oncologist? And then you go back and forth, and then you get a scheduled date potentially for what we call a tissue biopsy. Okay, that's almost 5 to 7 folk you're supposed to keep up with. And every person, every physician is layered now with what we call professionals. And so I think this is one of the things we have to recognize, and so that we're not making it very easy as a business structure for patients to get some answers. And so I hope that the platforms like this can help someone make a checklist about what they can do if they do have these questions, or even reference back to this presentation and say, wait a minute, they said I'm supposed to do this, this, and this.
Right.
So thank you, Mr. Dean, for that as well.
Keep a folder with all your stuff. Go ahead.
I want to piggyback on that. Thank you. That also ask questions. No question is stupid. No question is dumb. Some people feel like I can't ask the doctor because I don't know what they're saying, and they're going to say all these crazy words to me. It doesn't make sense. Stop them. Tell them, I don't know what you're talking about. Bring it down to my level. I don't know what you're saying. We're sitting there saying, the pulmonologist. If you don't know what a pulmonologist is, say, Doc, what the heck is a pulmonologist?
Right.
Use layman terms. So ask questions. Do not be afraid to ask questions. Also, ask if that cancer center or that doctor has a patient navigator. The patient navigator is like a social worker who their job is to help you navigate through this process. So many cancer centers will have patient navigators specifically for lung cancer, for breast cancer patients, et cetera, because they're pretty well versed in this is a lung cancer patient, so I'm going to need to have them see the radiologist. I need to have them see the pulmonologist, and they'll set up appointments for you. They'll contact you and remind you about your appointments. So a patient navigator can be an invaluable resource if that cancer center has that. But again, like Mr. Dean was saying, keep a folder, keep records, take notes, bring somebody with you. I know with COVID, it was more difficult to have someone with you in the doctor's office, right? Yeah, but I think now a little bit we're loosening up the rule. Right, exactly. You can bring someone in.
Now with Omicron, I don't know.
Well, this is our plug now to ask people to get vaccinated. And to increase our vaccination rate, particularly among vulnerable communities. That would be us, Black communities. I know people have a right to make their own decision. Don't want to take that away. Right. But it looks like we're continuing to spiral within this virus that continues to mutate, which viruses do. And the only thing that we have is our vaccines. And so, I think you even had the creator of the vaccine, Dr. Kimberly Corbett, on your show. And that's a more expansive show. But I think that, number one, even for people for cancer patients, getting any of these viruses is deadly or puts you at a higher risk of death. So we definitely are. And then if you've maybe survived cancer and had a lung transplant, again, you definitely need to be vaccinated and not be exposed to these viruses. So that's our plug, particularly as we enter the holidays, and we want our families at the table. I know I enjoy seeing folks at the table.
Yes,
I would
indeed.
say this, and as we're wrapping up here, I want to thank Dr. Singleton for joining us. Thank you, Dr. K, for stepping in, for Dr. Gigi, and putting this whole
Yes, my
program
Gigi.
together. So we're going to send her some prayers, and I'm going to send her a text message after we get off air. I'm going to see scrolling along the bottom of the screen is blackdoctor.org. We have a cancer resource center. And
Yes.
as videos, this video will be on there tomorrow. We're going to
Good.
upload these videos. We got a lot of videos and articles all about all types of cancer: myeloma, colorectal, prostate, breast, and lung cancer, the big 5. So go to our Cancer Resource Center, get your questions prepared, get some questions answered. So when you go into your doctor. So I want to say again, thank you all for joining us this evening. We really just, lung cancer it's what it is, but knowledge is key. And being armed with that knowledge, you have a better chance of surviving it. So again, thank you all for joining us, and we will see you next time on House Calls.
Thank you. Happy holidays. Thank you, everybody.
You know what? Let's play your video as we're going on. We're gonna play the video one more time.
Thank you. I appreciate it. Thank you.
That was a great video. So I'm gonna share this video one more time. Okay, audio.
You and your best dude always hit the basketball court. You always play until exhausted, with your faces to the sky, your backs to the concrete, and your future to embrace. Your lives have a constant threat: the air you breathe. It puts you at risk of lung cancer. African Americans are disproportionately affected by lung cancer. Black men die from lung cancer more than any other race in the U.S. They are diagnosed at an earlier age due to early exposure to the leading cause of lung cancer: smoke. Let's clear the air for our little boys. Put the cigarettes down. Stop smoking. It's never too late.
Thank you. I appreciate it. Good night. That's a good way to end. Thank you so much.
Y'all take care.
All right. Bye-bye.
Take care.